Hi guys, Dr. Keber here. Today I'll be talking about the effects of pregnancy on the glucose metabolism in relation to diabetes in pregnancy. So, gestational diabetes mellitus, as defined by ACOG, is a disorder of carbohydrate intolerance of variable severity with onset of first recognition during pregnancy. Its prevalence in India is about 10 to 14.3% according to Government of India 2018. So, how does pregnancy affect the glucose metabolism? First of all, the goal is to provide an uninterrupted nutrient supply to the fetus, which will augment the maternal body stores to meet the demands of lactation. So what happens is, in normal pregnancy, in the first trimester, that the basal insulin level and glucose intolerance remains the same. But as the pregnancy progresses, the fasting blood sugar reaches nadir at the end of first trimester. With advancing gestation, as the placenta increases, the levels of placental hormones also increase. So the hormones such as HCG, prolactin, estrogen, progesterone and cortisol, all of these are responsible for increasing the insulin secretion as well as increasing the insulin resistance. They also increase the hepatic gluconeogenesis. The result of this is increased plasma glucose levels with fasting hypoglycemia, postprandial hypoglycemia with preferential diversion of glucose to the fetus, and insulin resistance. Fasting hypoglycemia occurs because of the continuous draw of glucose by the fetus. So, in patients with GTM, what happens is there is increase in a marked peripheral insulin resistance. That is, there is more peripheral resistance than what normally should result in pregnancy. Insulin has an effect of inhibition on hepatic gluconeogenesis, which is lost in GTM. So there is raised hepatic gluconeogenesis. With insulin resistance and raised hepatic gluconeogenesis, more glucose has been formed, and which is now in the maternal blood. This maternal glucose will now increase the fetal blood glucose. The PEDERSON hypothesis says that when there is increase in the fetal blood glucose, that is fetal hyperglycemia, it will lead to stimulation of fetal pancreatic cell and hypertrophy, which will result in fetal hyperinsulinemia. There will be increased fat deposit around the organs, especially around the heart and liver, so which will result in organomegaly, macrosomia, increase in erythropoietin secretion, and decrease surfactant production. This will result in macrosomia. So there will be difficult delivery, so raised